Well, thank you very, very much for allowing me to be here. I really appreciate it. Both chairs, thank you very much. I think I might need a standing stool because I'm feeling very small. I was just sitting between Dr. Mohit and Dr. Chua, and to be in a room with so many great surgeons, so many legends, it's very humbling. So thank you very much. I'm wearing a green jacket, which means there's either eggnog, green beer, or it's the Spine Masters course, so that's pretty awesome. In the next 15 minutes, or maybe even a little faster, I'm going to impart everything I know about robotics to you, all of it, all at once. So my disclosures help explain kind of why my perspective might be helpful. I've been active in this area since 2015, and I've had an opportunity to do a lot of teaching over the years, and I've really enjoyed that. A lot can happen over 9 years. My initial uses were drawn to patient safety. We see the improvement in accuracy, and I really felt that we were doing a service to our patients by advancing the art. I was really excited about this, and Izzy Lieberman approached me at one point and said, "Hey, Andy, the robot's ready for you." And so I talked to our hospital administration, and we talked to industry, and we worked out a deal, kind of a pay-as-you-go kind of deal. And I was able to get a robot. And it was the first one here in the Pacific Northwest, and we were able to start using it. And there are some limitations to the first-generation robots. They're a little bit harder to program, take a little bit longer. There's some expensive, expendable components that go with them, and there's just some challenges. And some of those challenges have been improved. Some of them still remain. But it was overall a very good experience for me. The administration people found it to be very helpful as well because we got into this space early. There were some advantages for them from drawing people out of market and some advantages to the advertising kind of standpoint of it. Concurrent with this, we were also developing a robot program, and so there were some efficiencies that came with that as well. I was really impressed with how accurate these machines could be. Even the early ones were 98% accurate in most studies, and in fact, these studies were duplicated, and they found that most of the time that number was around 97, 98% for where you had perfect screws, and then the ones that weren't perfect, very rarely there were revisions. I really scoured the research and could really only find 0.5% revision rate. That was the highest one I could find, and that's in the study down below there. Being fairly early on in this robotics revolution, I had experiences that were easily obtained and some that were very difficult and challenging, but I've greatly enjoyed being afforded to have these opportunities and then to share it with other surgeons. And I'm not going to lie, using a robot's very ego compatible. There's nothing bad about feeling like, oh, I'm the robot guy, and sharing that. So it was great to work with industry in those early days and to help with this. And I think that process is still going on, and you saw that with the previous talks. So like performance athletes, surgeons benefit the people around them. And so, Michael Jordan made a lot of money for Nike by bringing a new credibility to their brand. And the parking lot owners near the stadium here love it when the Seahawks play at home. The hospital administrators capitalized on the fact that we were able to do more, that we were bringing in people in from out of market. We had shorter lengths of stay, and it allowed them to have some prominence. And so things really were continuing and cooking and going great for quite a while. There are some limitations in those early machines. One is it's attached to the patient, so it kind of limits as far as how much you can share it with other surgeons and bouncing rooms and that sort of thing. They can take a little bit longer to program. Fortunately, my girls are in ballet, so I had a lot of ballet rehearsals where I could program. Frame shift errors still remain a challenge today, but were a much bigger deal back then. There are expendables that have a cost, and then we were having inconsistent reimbursement on the coding. You could build a navigation code, but then it's not really navigated, and it took extra work. So even when it was covered, you had to pay an employee to do that. This is an example of frame shift error, and this is actually from a navigated case, not a robot case, but you can see that the screws are actually in really a nice trajectory. It's just that the spine's in the wrong place. And that's the challenge, is you have to be able to recognize when things move and be able to correct for that. And there are some strategies that have been developed over the years that can be very helpful for that, and some warning systems that are involved in the robots now. And then we've talked about Skive a little bit. You've heard other people mention it. This is actually, I think, a pretty nice illustration showing how, unless you have a perfectly perpendicular starting point for your drill, it's possible for the drill to move down that slope. And so there's tools that can be helpful to flatten out that area, or a burr to open it up, and there's things, but you have to be cognizant that this is a possibility and program appropriately for that. So as I said, our program was just cooking and just doing great, and everybody's pleased and happy. And then, in case you were born yesterday, something happened. And in Washington State, our ability to provide healthcare to patients was damaged in many ways irreparably by well-intentioned but draconian measures that were taken during the COVID-19 epidemic. And our robotic program was disproportionately affected by that because it's all elective. And coincidental with that, we also had a change of ownership in the hospital system I worked for, and they were less enthusiastic about robotics. And then, to be perfectly frank, and industry got a little bit more competitive as more players came into the game, and there wasn't quite as much of the working together collegiality that was going on. So there were some challenges that occurred. And so when I look at like the 9 years that I've been using robotics, there's my pre-COVID time and then my post-COVID time. And so with adversity comes opportunities. So while we were in sort of these dark days, one of the other hospitals in our town was gifted a robot, and then we were actually able to ink a deal on a Gen 2 unit, which, one of the things I was supposed to talk about is how we did it. So we actually did it on a program where my usage alone was the one that was the basis for that. And that's important because our first deal was based off of a group of surgeons using it, and it turns out that one of them retired and one of them left, and then it became one guy. While we had these dark days, though, it gave me an opportunity to really dig deep and see what the capabilities of these machines are. I had opportunities, days where I wasn't able to operate, but I was able to practice and work and go to courses and to really push the limits. So we were able to come up with what I'm using it now for, this post. And so anything that requires precise localization, I use these machines basically every time I can. I hear frequently from people saying, well, I see where that would be helpful for the big cases, but they don't want to use that in the little cases. I actually say people should use it all the time. The skill set that you develop on the little cases will also help you on the big cases, but then there's advantages. We had heard one of the speakers mention about the fascial incisions, where you make a central skin incision and then do your screws through the fascial incisions. That's actually really helpful on single level L4, L5, grade 1, grade 2 spondies. That's actually a great way to do it. The patient only has one wound that they see on their back. You've spared the paraspinal muscles from the pressure damage from their tractors, and that's a great example where the robot can be helpful in just that little case, as it were. I think the ability to precisely control where your inner bodies go, especially with expandables, you can correct a lot of these deformities that used to be T10 to sacrums with shorter constructs. And there were some beautiful examples that we saw earlier where lateral arthrodesis was also used in that. Lateral arthrodesis with the frame-mounted units, the Gen 1 units, is very challenging because the frame would shift. Gravity works generally in an up to down direction in our perspective. And so on the side, you could see the frame sag. Well, it's not as much of an issue with the second generation units. And so lateral arthrodesis and doing single position laterals became a bigger part of my practice. And then osteotomies. I'm going to show you a picture of an osteotomy that I was able to achieve very quickly. And there's some real advantages to doing quick osteotomies because they tend to bleed a lot. So the faster you can get them done and close them down, the less blood loss you're going to have, and the less likely you're going to go to the ICU, the less likely you're going to need to transfuse and that sort of thing. Perc screws following A-lifts, and then being able to move the machine back and forth in between different rooms for other surgeons to use, or you can bounce. I think as an education tool, these are very powerful. The thought processes that go into planning the screws, maximizing the minimal pedicle, figuring out where your rod's going to be, avoiding the other hardware. These are all tools that help you live in that space so that your mind is constantly thinking about where it's going to be. It also offloads it that you're doing that before you even get to the operating room, so you can really concentrate on doing what you're there to do, which is to help the patient, get the pressure off the nerves, correct the deformity, have them have a better life. So, like I said, the frame shift errors that we were challenged with earlier machines, not so much with laterals. You can get a really nice position. I do tend to put the screws in first and then use a sterile adhesive drape to limit the exposure since it is down low, then do the lateral, correct the table, and then place my rods. And you can get a pretty decent construct with that. This is the osteotomy case. So this lady had 6 prior surgeries before coming to me, and a variety of hardware in there, and had consistently fractured at this site of non-union. And we wanted to be able to correct her in both the AP and lateral plane, and so we had to do a biplanar osteotomy. So planning exactly where we wanted our cuts to be, we were able to achieve that relatively rapidly, and get her lined up and get her healed, and do this without actually having to do a transfusion, which by the time we got everything opened up and debulked, it was a fairly large surgery. So very pleased with that ability to do that. You know, the machines are accurate. You can use them in the cervical spine. I'm now doing C7 pedicle screws routinely. It's very helpful. I think the thoracic, we saw great examples of thoracic trauma. Internal bracing with these can be done perfectly percutaneously. And then sacral cases. So we saw that as well. Revision, even SI fusions are very easy to do with this. The Cabase screws, the S2AIs, also very easy to place with this technology and safe. But what can't they do? And so they can't correct indications. Dr. Chapman had mentioned, you know, he looks at the index films and says, why did they do this? And the robot can't fix that. You know, the AI and the incorporation of that as we move forward, you know, why are we treating this? What is the pathology? What are we trying to achieve? The parameters becoming pre-programmed into these planning softwares. These are going to be helpful, but it really does come down to us as a surgical community. You know, I'm the only spinal deformity surgeon for a 5-county region. And I've seen improvements as we've gone forward over the years, but I still think as a spinal community, we can do better. And so there is a role for fundamentally teaching our surgeons, teaching our fellows, teaching our residents, and policing each other as far as what are the best indications, what are the real reasons we want to do this, what are we trying to achieve, and always keeping that patient primarily in our focus. Another issue is what happens when the robot doesn't work, you can't get registration, you know, and that question, everybody gets it all the time, and I've heard a variety of different answers. Having 2 teenage drivers now, you know, I didn't start either one of them out on a horse, but we did get them up into cars. And I think the ability to place an open screw is something that is important, and I think it's best left at the cadaver lab as these techniques routinely become more and more minimally invasive. But it is good to know. There are times where you might be practicing in an austere environment. There are times where equipment doesn't work, and it's nice to have those skill sets there. There are some challenging cases that can come up where maybe you do need to use an older technique to fix the patient, because at the end of the day, you want the patient to do well. The robots don't have their own brains yet, even with AI. That may be a challenge, and so we do need to be able to think about what's the next step, where are we going, what is our salvage plan, what's our backup plan, and then of course we can never take back what we've damaged, so we have to be very careful with our tissues, and that's where pre-planning incisions can be very helpful. So there is a noted benefit in decreasing the time and the energy necessary for the spinal instrumentation, and that allows you to focus again back onto the patient, and I really enjoy that a lot. One of the things I don't particularly like is that my attention is drawn from the patient onto the screen. You know, I'm drilling and the patient's here and I'm looking at the screen, and so I'm really looking forward to that overlaying of the technology where I will be able to literally have my focus on the patient and still have these benefits. We've seen it starting to come in now where we're going to have some end effectors that can actually do some of the cutting for us. I think one of the things I had talked about at Spine Masters course a couple of years ago was the next real big step is to be able to tell the machine what you want it to do and then have it do it. I'm sending you off to go do it. And I think that's, as we get into these ultrasonic bone scalpels, the specialized burrs and such, that we're headed that direction, and that's going to be really great. The Da Vinci, having multiple wrists and elbows and shoulders that can do stuff that humans can't do, get into places that we can't get into, that's going to be a really neat addition to it. But none of that stuff happens for free. And so I think the recognition that robotic surgery, particularly in the spinal world, is a specific skill set, and it requires additional training and knowledge and know-how, could be recognized by a code that could be reimbursed. And I think as a community, we should ask for that and support that becoming a thing so that we can get this technology to our patients consistently and in every market. It shouldn't just be for the elites, right? We should be able to get this to our Medicaid patients and to the people out in rural areas and places where they may not have access to this. So I had said a couple of years ago that I thought that robotics was going to become the standard of care, and it's really not just my words. Dr. Johnson, who will be talking a little bit later, said this back in 2014, so it's pretty exciting. And this is where we're headed. So Star Trek level, we're not quite there yet, but we're headed that way. And I think with the incorporation of large-scale data, AI, and the daily advances that they're having in engineering, we're going to get there quicker than anybody's really thinking. I mean, imagine telling this guy that we were going to be doing this, right? It happens very, very fast, and it's exciting to be part of it. I'm so grateful for the opportunity to be here, and I will be happy to take questions over email. I know we've got a time crunch. Thank you.
Wow. As member of the Manual Transmission Society, an avid fan of the three-pedal construction, yes, I drive automatic also. There's another aspect of cost that we have not looked at and talked about, and that is the tech cost, not right. The acquisition cost, but we do seem to need somebody who's quite tech savvy in the room to help us navigate and mediate. So this is not just all in our iPhone or Samsung phone, don't want to be product specific here. But Apple stockholder, full declaration. But it is a significant issue with trying to make this work that we need a knowledgeable human being. They're usually corporate sponsored. And we now have a situation where some companies charge a not insignificant cost for such a knowledgeable person to be there. Very high on weekends if we don't use the products of that company. And that may not be totally unreasonable. There's a cost involved, a human labor cost, a knowledge cost to kind of navigate, literally and figuratively. So how do we navigate that part, the financial part, in a reasonable fashion that is cost effective in an area where, for instance, an L405 single level fusion is considered a commodity procedure, especially in Medicare with extremely tight cost margins. So whose job is it to have these, the hospital or industry, or is that born of our so-called revenue?
Well, I think we're in a temporary situation with this. And when we've been using automobiles as an example for several parts here. But with automobiles, when they first came out, a complex machine, brand new technology, and the elite people that could afford these things had chauffeurs, literally dedicated employees that knew how to operate the machine, care for it, and all that. And that was because these were unfamiliar, these were new, there was a lot of going on. But as the generations go on, I mean, I don't think anybody here, except for maybe Dr. Chua, got here with a chauffeur today. So it became more friendly and usable. And I think that's the case with these robots as they get forward and forward. I mean, clearly the ability to program the unit that I use predominantly now, it's way easier. Drag and drop. It is almost like an iPhone. which is a big step up from the one before that. I imagine as we get into third and fourth generation robots, we'll have much less need for that sort of technical support. Now, there's always going to be big challenges. I mean, if you go out to your garage and your Tesla just doesn't work, well, that's, this is beyond just lifting up the hood and changing a spark plug at this point. So I think there's always going to be some sort of service agreement where the companies are willing to come help you on these things. But I could see that the situation you're describing here, I believe, is a temporary moment in time before we get to that critical mass where everybody knows how to use these machines and troubleshoot them. Dr. Chu, I see a question.
Yeah, great talk, Dr. Manista. Trying to use the microphone. As always, and Dr. Chapman, a very enlightening question. And I think the important part of that is, as surgeons, we actually need to know the lingo. We need to know the vocabulary about cost-benefit ratio, not just RVUs and what we take home every month, but we need to understand this from a system perspective, because we're all part of the system, whether you're private practice, academic, employed. And the most powerful data that they need to have, the hospital systems, is not how much does it cost, but how much do we save. And so we need to be able to provide hospital systems that the data that Rick Chua's patients get out of the hospital in 24 hours or less for a one-level fusion, whereas everyone else in that hospital system, not Dr. Chapman's, not Dr. Manista, the other doctors in my hospital system, it's 4 days or 5 days. And those bean counters can tell you exactly what it costs to be in the hospital for 24 hours for an elective spinal surgery. So spine surgeons need to understand the lingo, the vocabulary. You need to know what a DRG is. You need to know what the reimbursement to the hospital is for that DRG for the one case, whether it's a posterior fusion alone or an anterior and a posterior fusion in the same setting in an outpatient basis, so that the bean counters understand what they're saving, not just what they're spending for us to use.
Yeah, that's a very good point.
Yeah. Great.
Well, thank you guys very much. I appreciate it. I look forward to the rest of the talks.